my name's Nigel North. I'm a clinical psychologist here. I work a lot with Wessex Rehabilitation Centre in the field of chronic pain. One of the difficulties with being a psychologist working in the field of pain is that everyone thinks that we're trying to suggest pain is in your head or imaginary or made up. And many patients tell me that they've actually been told that or it's been implied. It's really important that you understand that's an old-fashioned, out-of-date idea and it's completely wrong. This talk is about trying to help you understand how psychologists have worked alongside chronic pain to understand how things like anxiety and depression affect it. And I'm going to show you some of our research on that and try to help you understand that the idea that some pain is somehow made up or imaginary is completely out of date and wrong. So when I talk about mood disorder, I'm talking about, and I'm going to explain what these things are: anxiety, depression, and post-traumatic stress disorder, which I'm going to call PTSD. And I'm going to go through each one of these and talk about it in relation to what it does to pain and pain intensity. So when we look at the research on these things and chronic pain, we find that anxiety and depression are very common in people with chronic pain. So in terms of anxiety, more recent research suggests that up to 75% of people with chronic pain also develop anxiety. The important point here is it's a very common issue. Anxiety is a very common issue that accompanies chronic pain. And we get a similar picture with depression, but it's up to 85% of people with chronic pain can become depressed. So it's very high. It's a very, very common factor in the field of chronic pain. And one of the things we've understood as the years have gone by is that a lot of the depression in chronic pain is undetected. That is, that people are depressed, but they don't get help for their depression. And I'm going to talk about that again in a minute. So anxiety and depression are common in the field of chronic pain. PTSD, post-traumatic stress disorder, it's relatively new in the field of chronic pain, but it's thought with our recent research that as many as about 50%, half of people with chronic pain have PTSD. And I'm going to talk about the causes, because the causes of PTSD and chronic pain have been examined in the last couple of years, and it's really quite a complicated story. But I'm going to, if you bear with me, I'm going to come back to that a bit later on. So let's go back to anxiety. There's lots of symptoms of anxiety, and people have their unique set of symptoms. I've just got a slide here with some of the more common symptoms of anxiety, things like heart racing. Some people talk about palpitations, heart beating in their chest very fast, sweating, feeling very, very hot, breathing faster, their mind racing, unable to relax, feeling restless and fidgety, worrying thoughts going through their mind all the time, can't switch their mind off, their thoughts off, difficulties concentrating, feeling tense or wound up, feelings of fear or very strong feelings of fear, and for many people they have panic attacks. These are some of the symptoms of anxiety. There's a theme here. The theme here is things speeding up. So the body is speeding up, heart going faster, breathing going faster, but the mind is also speeding up. So things are going faster when people are anxious. If we look at depression, slightly different. So when people are depressed, they feel down and low in mood. They lose interest in things. They lose interest in parts of their life, maybe their appearance, hobbies, that sort of thing. They no longer get any pleasure from life. They enjoy things, and they don't look forward to things with any enjoyment. They lose motivation. Life often seems to be a bit pointless or having very little, no meaning. Again, difficulties with concentration, difficulty with memory. People find it very hard to remember things when they're depressed. and a loss of sense of humour. So the theme here, and there's other symptoms as well that people experience, this is not an exhaustive list. The theme here is things are slowing down. We're stopping things when we're depressed. When any of us are depressed, we tend to stop things. Now, so the anxiety is speeding up, the depression is slowing down, the theme. Some people have both anxiety and depression, so it's you're going to be both going on, which is a very difficult situation to manage. PTSD, post-traumatic stress disorder, that occurs when one is exposed to a traumatic event. And there's been a big debate about when is a trauma a trauma. So the most recent thinking about this is that a traumatic event is what people say it is. So if something happens that you think of as traumatic, then it's a trauma. It doesn't matter what anybody else thinks. So I'll give you a couple of concrete examples. I do a lot of work with ladies the women have had babies, and quite often the women will say, the birth of my child was traumatic. If you talk to the midwives will go, no, it wasn't traumatic, it was a very standard birth, no problems, no issues. It doesn't matter what the midwives think, it's what the woman in question thinks. So she sees it as a traumatic birth, then it's a trauma, it's a traumatic event. Similarly, I saw a patient the other week who had fallen down an inspection cover, manhole cover, and injured his face, and he thought he was going to die because his nose was bleeding quite a lot. And he started to develop symptoms of PTSD, but the accident emergency consultant that had seen him said, well, he wasn't going to die, it was just straightforward nosebleed, there's no problem at all. It doesn't matter what that consultant thinks, it's what the man thinks. So a trauma is very individual, it's subjective, it's what people say it is. So if you're exposed to a traumatic event, you may develop PTSD. If you witness a traumatic event, seeing something that's traumatic, you may develop PTSD. Learning about or being told about a traumatic event that's occurred to family or friends, you may develop PTSD. And if you get repeated exposure to traumatic events, then you may develop PTSD. So what I call first responders, the people on the end of the 999 telephone, often get repeated exposure to traumatic events because of the job they do. And so many of them develop PTSD. Not everybody, but if you've been exposed to these traumatic events, you may develop PTSD. And the symptoms of PTSD, there's several groups of symptoms. The first group is called intrusion, and intrusion symptoms are symptoms that happen and you can't control them. So things like nightmares, where you may have terrible dreams, frightening dreams about whatever's happened to you, flashbacks where you're awake and you relive it. Some people say it's like watching a video of the traumatic event. And intrusive thoughts, these are just thoughts that come into your mind when you don't want them to. You can't shut them out. So these are called intrusion symptoms because they just happen to you. You can't stop them. It's one set of symptoms, you just need one of those. Then avoidance symptoms are where one actively tries to avoid thinking or talking about a traumatic event or being reminded of it. So whereas the intrusion symptoms, you can't control them, the avoidance symptoms, you are trying to bring in avoidance, you're trying not to talk about it, not to think about it. You only need one of those. And then the third set of symptoms are what are called cognition and mood effects. That's where people feel irritable, short-tempered, snappy. They think in a very negative way. They're emotionally, they talk about feeling numb, and they have problems with memory. So you need one of those after a traumatic event to be told you've got PTSD. And the final set of symptoms is what's called reactivity. That is where you are what they call hypervigilant. You're constantly expecting bad things to happen. So you're hypervigilant for danger. You can think the world's a dangerous place and anything can happen at any time. You have a startle response, that is you're extremely jumpy, but with the jumpiness often comes distress. So you might jump if you hear a car backfire, but you probably normally you don't get very upset about it. When you've got PTSD, you get upset about it, as well as being very, very jumpy. Problems with concentration and problems with sleep. So if you've got about one symptom from each of these areas, then we start talking about PTSD, particularly if you've been exposed to a traumatic event or witnessed a traumatic event, that sort of thing. So this is PTSD. Now what you notice there is some of them are about slowing down and some of them are about speeding up. So it's a bit of a mixture of both, in fact, of speeding up and slowing down. So what we see is that anxiety, the theme is everything speeding up, depression's slowing down, PTSD is a mix of the two really, speeding up and slowing down. And some people have all three of these, which is a very, they call it an unholy alliance. That's a very difficult situation. So what's this got to do with pain? So I want you to hold in your mind what I've just said to you about anxiety, depression, and PTSD. And I'm now going to talk about a particular theory of pain called the gate control theory of pain, which was developed in the 1960s by two people called Melzack and Wall. And what they were trying to do is they were trying to explain some research findings that were available to us in the 1960s. So the old idea of pain was that if you got an injury, so if you hit your foot with a hammer, silly example I know, but I'll make this point. If you hit your foot with a hammer, the pain impulses would shoot up your nervous system, up your spine to your brain. And that's where you'd feel the pain. The harder you hit your foot with the hammer, the more pain you would experience. That was that in a nutshell, that was the old theory. But research started to show that people who did high-level sports, or any sport really, or would often get injured during a game, for example, but not feel the pain of the injury until after the game had finished and they were back in the dressing room or back at home. Soldiers in war would sustain injuries from shells, shrapnel, bullets, but they would often not feel pain until after the battle was over. People who could do things like meditation could often go into what looked like some kind of trance-like state and deal with all kinds of pain, like walking hot coals, that sort of thing. So these things didn't fit with the idea that the bigger the stimulus, the harder you hit your foot with a hammer, the more pain you felt, because there were certain situations in which that didn't follow. So Melzack and Wall wanted to devise and look at a theory that could explain how this would actually work. And I'm cutting through an awful lot of stuff here because it's quite a complicated story. In essence, they found that in the spinal cord, there were collections of groups of cells in clusters. And that these cells had a certain, I call it rhythm, they vibrated, if you like, a certain rhythm. And this rhythm, these oscillations, these vibrations, they would change in certain situations. They would get faster or they would get slower. And when they speeded up or slowed down, that would, because pain impulses were running up the spinal cord through these groups of cells, if they increased in their activity, then the pain impulses speed increased, they got faster, and pain became more severe. If they slowed, if the cells slowed down in their activity, then the speed of pain impulses also slowed down and seemed to reduce, didn't get rid of the pain, but it reduced its intensity. So these guys started to think of this collection of cells in the spinal cord like a gate that could open and close. So it's not like a 5-bar gate you can see going into a field. They were thinking that the pain impulses go through these collection of cells. If the gate is open, if the cells are vibrating or oscillating very quickly, then the pain is greater. If the gate is closed, i.e. the cells are oscillating more slowly, then the pain is reduced. So that's why it's called the gate control theory of pain. So this gate can be open, you get more pain, or closed, you get less pain. And they were using very sophisticated, for the time, techniques to look at these collections of cells, and they were able to identify them. So here's a diagram, if you like, with a little man who's got some kind of G-clamp on his foot. And the old theory, it says Descartes above it, because he was the guy who developed this, was that the stronger you turn the screw on the G-clamp, the greater the pain. And it was a direct relationship, direct connection between pain area and the brain. The gate control theory of pain said, well, you can get that when the gate's open, but the gate can also be closed and the pain impulses are slower. So we can do something to slow down the pain impulses or speed them up. And the big thrust, if you like, came when they were trying to find out what opens the gate or closes the gate. So if we open the gate, pain impulses go faster and the pain intensity increases. So there's lots of things that open the gate, but just some of them are things like not doing anything, inactivity, not having interests in life, not being able to concentrate on other things. But the three things I'm particularly talking about today are anxiety, depression, and PTSD. So when people got very anxious or very stressed, the gate would open, the cells would vibrate faster, the pain impulses would speed up, pain intensity would go up. And we see that a lot in patients who will often say, for example, if they're going to do some activity, I felt really worried about it, really stressed, and my pain suddenly got worse. That's exactly what's happened. It's not imaginary. That's often where people are told, well, it's imaginary, you've made that up. It's not imaginary at all. As you got stressed, so activity in the spinal cord changed, and your pain impulses got faster. So your pain got greater. And that happened as you became stressed. So these things were shown to open the gate, and there are other things they found would close the gate and create less pain. Now, closing the gate doesn't take the pain away. It's not like it removes all the pain, it just lessens it. So things like having interests in life, trying to think positively about things, practicing relaxation or meditation closes the gate, mixing with other people, socializing seems to kind of close the gate, and doing things, but pacing yourself, activity in a paced way, seems to close the gate. So, and there's lots more as well. So they found that the gate could open or close, and they could measure the speed of pain impulses from parts of the body up to the brain, and they could show that when people were stressed, for example, pain impulses did go faster. They could actually see it, they could measure it. So it's become an important theory, and that's why it's important to try to deal with things like anxiety and depression if we can. Because the obvious thing is, well, if depression's not good because it increases pain, why don't we just sort out people's depression and treatment for that? And I'll come back to that in a minute. So the researchers, Melzack and Walk, would show that pain impulses increased in certain situations. They could demonstrate that scientifically. They could demonstrate that mood disorder, anxiety, depression, PTSD, increased pain intensity. And so we think about these things like a volume control on an old-fashioned radio. If you get stressed, it's increasing the volume control. It's winding the volume up, and the pain intensity increases because the pain impulses are traveling faster. So it's important to understand that, because the idea that pain's all in your mind is completely wrong. And we can demonstrate that. So if you've ever been told that, or it's been implied to you, you need to try to put that in a bin somewhere, because it's wrong, it's out of date, it's old-fashioned. So let's go back to treatment of anxiety and depression. So if depression is common, which I started out saying it is, in chronic pain, then what many people do when they find themselves being depressed is they get given antidepressant medication. And there's lots of them, lots of different types of antidepressants. But the trouble is, these drugs don't work for everybody. So I see a lot of people who get put on antidepressants and they say, I don't feel any better. If that happens and the patient goes back to their doctor saying, I don't feel any better in terms of my mood, then often what happens is the drug dose is doubled and then doubled again in the future. and it may still not help. So lots of people end up on high doses of antidepressants, often taking it for a long period of time, and still say, I don't think it's helping me. So we need to think about why is that happening? So the theory about how antidepressants work is that when you get depressed, when any of us get depressed, there's a chemical in the brain called serotonin that reduces, it gets less. And serotonin is a kind of happy chemical. When you've got a lot of it, you feel happier. So if depression leads to a reduction in the serotonin in the brain, then if we can increase the amount of serotonin in the brain, we can improve mood. And if we can improve mood, we should help pain by closing the gate. So when the drugs, the antidepressants that are given, they actually put serotonin, they try to increase the serotonin in the brain. So if depression equals low serotonin, we give the tablets to increase the serotonin. Why is it not working for many people? And the latest thinking about this is maybe the theory's wrong. Maybe that the serotonin reduces and then you become depressed, rather than you become depressed, that causes a reduction in the serotonin. So if the serotonin reduces first, and it's a theory, remember, they're still looking at this. If the serotonin reduces first, and that causes a depression, you need to know what the cause of the reduced serotonin is. Because if you give drugs to try and increase it, and you don't know why it's got less, why the serotonin's got less, then it's a little bit like trying to fill a bucket up with water when there's a hole in the bottom, and you haven't done anything to block up the hole. So it might be that the serotonin's reducing, and we're trying to pour in the serotonin with a drug, antidepressant, but actually we can't get the levels up. So there's now an interest and a research program looking at what happens when we get depressed, what happens to the serotonin, and maybe this explains why the drugs don't actually why the drugs don't actually work for many people. But antidepressants are also that's under investigation, also only part of a possible solution. We also know from a lot of research that's been done that cognitive behavior therapy, CBT as it's called, including things like mindfulness, also need to be used alongside antidepressant medication to try to improve the situation, to get the best results. But it's very easy for me to sit here and say that because I know that cognitive behavior therapy is very difficult to find in the community, and that the waiting lists are potentially very long for the community services that provide CBT. And the services are often referred to as IAPT, Improving Access to Psychological Therapy. So we know that people need therapy in addition to medication, but lots of people end up on medication, don't get therapy, and the medication they get often doesn't help. So it's about understanding that, because if we can help people with depression or anxiety, then we can also help them with their pain. Just going to talk a little bit about PTSD, because this is very new and is a very current topic of research. So I've told you that PTSD can occur after a traumatic event, and your pain may have started after a traumatic event, like a car accident, or a fall, or lifting a heavy object. Or you may have PTSD to something else in your life. I see lots of soldiers who have got chronic pain, but their PTSD to things that happened while they were in the armed forces. So PTSD can occur from many other events in life that are traumatic, but it can also occur after things like car accidents or any other accidents which may start off with the start of chronic pain. So we know that, because we've done a lot of research here in Salisbury, people with chronic pain have undiagnosed PTSD. So the events often which led to the pain starting. I told you depression is not very well diagnosed. PTSD is diagnosed very poorly, and it's a relatively new concept. And we also know that PTSD symptoms can open the gate. They can increase pain intensity by opening the gate. So we know there's a lot of people with chronic pain who have undiagnosed PTSD, which is affecting pain intensity. We also know that when you've got pain, chronic pain, it's often characterised by flare-ups where the pain suddenly increases. Some people can predict a flare-up, but many people say it just happens. I don't know why it happens. And it's been found that many people find their flare-ups to be traumatic because they're so frightening and so awful for people. So most recent research, which is very, very new, has found that people can develop PTSD to their flare-ups. They can get intrusive thoughts about the flare-ups because they're so frightening. They can get flashbacks to a flare-up. Some people have reported nightmares to flare-ups and avoiding certain things which they think cause flare-ups. So people can get PTSD to flare-ups, and that's very, very new. But it gets more complicated. So you could have a situation like this. If your pain started following an accident, you could have PTSD resulting from the accident. You've got PTSD and chronic pain. If you then get flare-ups with your pain, you may develop a different type of PTSD to the flare-ups. So then you may have two sets of PTSD. You have PTSD to the accident which started your pain and PTSD to the flare-ups. So we call complex PTSD. And there may be other things in life that have nothing to do with pain that have led to you developing a different type of PTSD. So people can have a very complex situation with chronic pain, PTSD to say an accident or something else in their life, and PTSD to their flare-ups. So the impact of this on pain intensity is really severe. And there's a particular type of cognitive behaviour therapy we use to treat PTSD called trauma-focused cognitive behaviour therapy. Again, it's difficult to get in the community because the waiting lists are long. But we've only recently understood that this is a very complicated situation that people can find themselves in with their PTSD. So the most complex situation is that you can have chronic pain and also have anxiety and depression and complex PTSD. And unfortunately, there are some people we've just begun to understand have got this problem. So the impact of this on chronic pain, all of those things, will be very severe because the gate is constantly opening and closing with marked physical effects in terms of pain intensity, but also having psychological effects as well. So just to summarise what I said, I've tried to say that mood, anxiety, depression, PTSD act like a volume control on pain intensity, making it up and down. That these mood issues can either open or close the gate and therefore increase pain intensity. That it's really important to recognise mood problems like anxiety, depression and PTSD to help our understanding of pain. Treatment, which is the gold standard, the best treatment is antidepressants and CBT, is important in managing mood issues and pain issues. And the problem that patients often tell me they come up against is many healthcare professionals are unaware of this latest research and may mistakenly imply or even be told to the patient that the pain's in their head, imaginary or even made up. And as I said at the beginning, if it's been implied to you that pain's in your head or you've been told it, it's an old-fashioned, out-of-date idea, and you need to try and lose it. Again, I recognise it's easy for me to say that and difficult to do, but it's very clear how mood can change the speed of pain impulses and change pain intensity. I hope there was something in there that's of use to you and of interest, and thank you very much for listening.